Folks, I'm a physician, and I worked in a hospital for the uninsured, and often interface with my colleagues who are in an emergency room at some understaffed critical access hospital, but so understaffed that they frankly had to send all their patients to the hospital where I worked. And so a lot of what I will say now will reflect that perspective. Let me first go here. I'm interested in the Medicare wage index, in which hospitals with a higher cost structure get more. If you will, the more get more. Now, it seems as if under current law, you're based upon your geographic area. Rural hospitals in my state cannot compete with the urban hospital because of Medicare policy, which tells the urban hospital, we're going to give you more. And so, obviously, if you're a nurse and you have to decide where to work, you tend to go where you would earn more. The cost of wages, current policy does not have a floor or ceiling in place for an adjustment in which the cost of wages is considered when reimbursing providers. And so, as I just said, urban hospitals get more, rural less. I guess I could ask many of you this question, but Dr. Pink, does the lack of a ceiling or floor for the Medicare wage index, frankly, give a perverse incentive for the urban hospitals to keep increasing wages, to make it harder for a rural hospital in Louisiana or Iowa or Tennessee to compete and to be able to keep that nurse who lives close to home, home?
Senator, we have done some research on the various rural designations that Congress has created, and there are some of these designations where the wage index does play a key role. For example, one study we completed last year, we found that many of the sole community hospitals in the country, it's an important payment designation, but they are located in states which have lower wages, and therefore the hospitals that are eligible for that designation, in fact, there's no advantage to taking it. They take the PPS payment instead of the sole community. So I believe that it is an issue. We have not studied it beyond sole community hospitals, however.
Okay, I will say that Senator Isaacson has a bill of which I co-sponsor to put a floor under the Medicare wage index, which we do think would help rural hospitals substantially. Secondly, I'll stay with you, Dr. Pink. Over the last decade, there's been a lot of consolidation in hospital systems. Just for folks to see, Obamacare passed in about '09. That's kind of an inflection point. Whether or not it's causal or just associated, we don't know, but why don't you show others to see as well. But subsequent to '09, we can see that the number of consolidation episodes has increased, about doubling year to year. Now, we know that that increases cost. There's good data showing that prices at a monopoly hospital 12% higher than those markets with 4 or more rivals, and I could give more evidence to that. Dr. Pink, given that these mergers coincided with rural hospital closures, I don't know the answer to this, I'm asking you, has consolidation by large hospital systems reduced competition or increased prices and kind of resulted in rural hospital closures?
We have not studied urban mergers and acquisitions, Senator. I can say that for many rural hospitals and small communities, merging with a larger health system has been the only option available to them, where they are literally faced with the choice of, do we have nothing, or do we affiliate, or are we bought by a large system?
Now, Ms. Thompson raised the issue of these ACOs not being extended to the rural area, but presumably if an urban hospital consolidated bought a rural hospital, they would just extend their ACO out to the rural. Ms. Thompson, has that not occurred?
That has not occurred.
Now, pourquoi pas, as my French teacher would tell me to say? How come not?
The cost-based reimbursement model that is at place with critical access hospitals simply reduces any opportunity because they're reimbursed based upon their costs associated with the Medicare patients they're caring for.
Okay.
So they don't have an opportunity to see the shared savings associated.
So we get the consolidation, which may keep the doors open, but none of the extensions, the putative benefits extended to others. Let me move on. I got 9 seconds left. I'm going to fit one more in. Ms. Martin, we've heard about the rise of freestanding ERs in places like Texas and Colorado. Several of you have mentioned that when these facilities close, frankly, folks' primary complaint is, I want to have an emergency room nearby. Proponents argue the facilities are providing increased access to ER care in rural areas where not financially feasible to have an entire acute care hospitals. The opponents argue that they're cherry picking, and although I'm told they take anybody who comes, and that the physician-owned facility, the fact that physicians owned it, is an issue. Currently, the facilities are not reimbursed by Medicare or Medicaid patients. Ms. Martin, you work in Colorado. They're allowed. If we're to allow these facilities to be reimbursed by Medicare and Medicaid, would this be a good thing for your rural area, increasing access to rural ER care, if you will, or not?
I don't believe that it would be a good thing in the rural areas. The freestanding EDs that have originated in Colorado are all exclusively in the urban areas. They're not in the rural markets. And I believe in a rural market, the idea of an emergency department conversion from a critical access hospital is that you keep care located close to a community where...
Now, let me stop you for a second. It's impractical if somebody has a head injury. You're not going to have a neurosurgeon in a rural hospital, and quite likely not have a general surgeon. Just because the general surgeon cannot, my wife's a general surgeon, I'll use the feminine, she cannot maintain her practice because there's not enough volume and or your payer mix is so poor. So I thought the emerging paradigm is if you stabilize the patient, do as much as you can, but then transport quickly. Would that not work in Colorado?
I guess what I'm referring to is the freestanding emergency departments that have been created in the Front Range market. In our rural community, in the hospital that I work in, we do have general surgery, and some of the critical access hospitals that neighbor us, they do a lot of stabilization and transferring. That's what we do in the rural facilities. I think that keeping an emergency department in a rural facility is very positive and something that we need to do collectively. My statement was simply that the freestanding emergency departments that have started on the Front Range have not...
You got to wrap it up because I'm way over. Okay, I'm sorry, I didn't mean to interrupt, but I'm 2.5 minutes over, and my staff and my folks have been forbearing. I apologize. Thank you very much for your answer. Thank you all.